Local programming on KRWG made possible in part by viewers like you. Thank you.
Welcome to Fronteras, a changing America. I'm Edmundo Resendez. On today's program, we examine the state of New Mexico's health and that of our neighbor to the south, the state of Chihuahua. From the growing concerns of valley fever to the number of Mexican national mothers seeking to give birth in New Mexico, the Office of Border Health at New Mexico Department of Health seeks to create a binational network of care. My guest today is Paul Dulin, Director at the Office of Border Health. Paul Dulin, welcome to Fronteras, a changing America.
Thank you.
Let's start by discussing the border health relationship of New Mexico and Chihuahua. How difficult or how easy has it been to create a binational network of care?
Well, you know, being a border state, that is, there are 4 U.S. border states, Texas, New Mexico, Arizona, and California, that border the international border with Mexico. So it's a different dynamic, obviously, having an international border to your south. The health authorities in Chihuahua are very similar, have similar types of challenges we do in terms of infectious disease and chronic disease prevention programs. So since diseases know no borders, especially infectious diseases, we decided to reach out to them to try to establish a coordinated network of care along various themes. One is in terms of infectious disease surveillance, and we decided to use influenza, which is of interest and is a big killer, especially of elderly. Every year in our state, about 200 deaths are attributed to influenza and pneumonia complications. And similarly in Chihuahua. We were able to sit down with them, talk about the concept of a project, and then it's a question of trying to get them to get interest and get ownership in that project. Our first project was indeed setting up a pilot project in Juarez at one of the clinical sites there to do influenza surveillance, influenza-like illness surveillance.
What are some of the issues currently being assessed on both sides of the border to improve border health?
Well, you know, border health, a lot of people say, oh, well, that's like public health in Spanish, but really, you know, we have about 100,000 people moving back and forth across the border between El Paso and our 3 ports of entry in New Mexico. Even in Little Columbus, there's about 3,500 people that move back and forth across the border on a daily basis. So anything that's there is on our side. We share family, we share food, we share culture, we share language. And it really is all about trying to put together a coordinated network, because if we're not doing our job on this side, it affects people on their side, and vice versa. So it's not a question of us versus them, it's that how are we going to actually carry out activities, border health, public health related, but in the border setting between us in a cooperative manner. Is it difficult? It's been a long slog. It's taken about 6.5 years to get to this point. We have successful programs, and we've had some challenges to do things that we wanted to do. But yes, it's certainly possible to do as long as you have a horizontal one-on-one relationship with your colleagues in Mexico, that you respect them as they respect you. And as long as they take ownership of the activities and we take ownership of the activities, then there's a very comprehensive relationship going forward.
You mentioned the word difficult, and you know, which brings up, you know, the bilateral agreement that New Mexico established with Chihuahua. How difficult was that to set up, and how difficult or how challenging has it been to maintain it?
Well, you know, there never has been a bilateral framework health agreement anywhere on the U.S.-Mexico border. The agreements that we sign state to state cannot be binding because since you're dealing with 2 different countries, any binding agreement would have to be ratified by the Congresses of both Mexico and the United States, so obviously we stay away from that. Our Mexican colleagues do want some type of agreement in place to participate, so I think it was more important for our Mexican colleagues to have this agreement. We had worked out a binational regional planning, strategic planning workshop back in 2007 involving about 40 different organizations. This is in Luna County and also in Palomas, but also at the state level in Chihuahua. And then we hammered out all these activities that we decided to do together in the binational setting, and then frameworked those within an agreement that was then signed by then Governor Bill Richardson and his counterpart by SRAS in 2008, and also the Health Secretary signed at that time. That was the first framework bilateral agreement between two states. Other states have signed, Arizona, Sonora, California's, Texas, and a number of its border states, on specific activities, specific projects, but never one that essentially included all the activities in the strategic plan that we had worked out together. Dealing with lawyers on both sides, dealing with exact language, leaving the agreement open so that anyone could cancel at any time, again being non-binding. But it worked out very well. I think we achieved 90% of the activities that we agreed to do based on the 2008 agreement. With a change in government both in New Mexico and in Chihuahua, the new governors and new health secretaries signed a follow-on bilateral agreement. In Mexico, no governor can sign some obligation past his or her own government, the 6-year period. So that's where this new agreement came in. And since both Governor Martinez and Governor Duarte came in about the same time, it worked out. We did another agreement, and we continue to implement today the activities agreed upon.
You mentioned some of the other states like Arizona, California, and Texas. How does New Mexico rank against those states in terms of the border health and the relationships and improvements over the last several years?
New Mexico is a more rural state than Arizona, California, and Texas. We have fewer population. That said, being more rural has its own challenges, and also being very near a large metropolitan area, as you have in Juarez and El Paso, a very large area. Arizona and Sonora have had a very long and fruitful relationship, both as state governments, but especially in the health sector. They meet quite often in a bilateral, binational setting, and work on programs together. So there's a great trust factor there. We've kind of used them as a model to go forward. It's a lot about the relationship that you have, and also working around meaningful activities, meaningful themes, not just health diplomacy, as we call it, which is meetings, backslapping, and all those types of things, but we really need substantive, on-the-ground epidemiology and surveillance, health promotion and education, and interventions where we can do them together. Texas has it more complicated, very large state, very long border. Texas shares its border with 4 Mexican states, 4 Mexican border states. And that relationship is differentiated with each one of them, so they have much more of a challenge than New Mexico does.
How has the drug violence affected the relationship, partnership between New Mexico Department of Health and its counterparts in Chihuahua and, with the citizens of both states?
Well, obviously the violence changed pretty much everything. We used to go into Mexico a lot more than we did in the recent past. I still continue to go in. We have important meetings in Nuevo Casas Grandes, in Juarez. Occasionally, if it takes us there, to Monterrey or even Mexico City. Obviously, the violence and its impact on Juarez, that was the first place where the brunt of the violence, of course, was felt, being the so-called homicide capital of the world. Not any longer, thank goodness. Things are getting somewhat back to normal. But immediately, our intent to rotate meetings, we have a BiNational Health Council that involves health authorities in Chihuahua, in West Texas, and southwestern New Mexico. The Texans could not travel to Mexico. There was a state order that no state employee could travel into Mexico. It still stands today. Thank goodness we haven't had that restriction. However, you have to leave it up to staff. Some staff just absolutely don't want to go over. Certainly the violence has been overhyped, but it's not to understate its impact on every aspect: the economy, the relationships, free movement of people back and forth. That said, we had continued on with our activities. If you know where to be, who to work with, there isn't that much of an issue. However, violence can flare up at any time. You could always be in the wrong place at the wrong time. But in all the trips I've taken into Mexico, and that might be 5, 6 a year, never have encountered any problem, and I hope that's always the case.
Let's talk about some of the current health issues. One of them being valley fever. In 2011, Arizona reported nearly 16,500 new cases of the disease, and California reported nearly 4,500 for that same year, while here in New Mexico, there were 75 cases. Before we get into current numbers, what exactly is valley fever?
Well, valley fever is a disease that's caused when a human inhales a spore. Excuse me, I should also say pets, cats and dogs get this too. In fact, in many cases, veterinarians know more about, many more veterinarians know about valley fever than clinicians, possibly. It's a fungus called Coccidioides immitis that is found in desert soils, both in the Chihuahuan Desert and also the Sonoran Desert. It especially impacts California. That's where the name comes from, the San Joaquin Valley, so valley fever, and also the corridor, the I-10 corridor between Tucson and Phoenix is especially heavy with the disease. Why there? The science is still not complete. We don't truly understand why this fungus would be more prolific in this area versus our area. That said, the tests back in the research back in the 1950s, late 1950s, indicated that New Mexico had between 5 and 30% of its population exposed to this particular disease. Now, exposure doesn't necessarily mean illness. 60% of the people who may have inhaled a spore, what happens is the spore is inhaled, it goes down into the lungs and starts to reproduce. With healthy people, in many cases, they immediately synthesize or otherwise encapsulate, and the particular spore doesn't start reproducing. The body's own antibodies take care of the disease. People become immune. However, 40% do develop some type of illness, and that may, the primary form of illness is like flu-like symptoms, perhaps a little more intense, but they're prolonged. Flu, you might be sick a week or two. With valley fever, it can go on for months. So it mimics influenza-like illness and then turns into a pneumonia, essentially. But it's not a bacterial pneumonia, it's not a viral pneumonia, it's a fungal pneumonia. Unfortunately, when the spores start to reproduce in the lungs, then little spherules burst and more spores get into the bloodstream, and they may lodge anywhere. They can lodge in the brain, they can lodge in the joints, they can become skin eruptions, they can turn into tumors in different parts of the body, including the lungs. So it's a very serious disease when it becomes disseminated. In other words, it's taken off from its point of entry and goes throughout the body. And it's different for different people. That affects 2% maybe of those that are exposed. Another 4 to 6% have recurring symptoms that may turn up like a kind of an influenza every year or a pneumonia every year. In most cases, people get well on their own and develop immunity, but then some people do need treatment the rest of their lives with certain medications.
What areas of New Mexico are affected more with valley fever?
The pretty much half of the state, roughly, is in the endemic area, which would be the extent of the Chihuahuan Desert, which extends all the way to Socorro, and farther east also. Again, it's hard to say. What happens is people can come down and visit, for instance, down in the south, and then go back to Santa Fe and have inhaled a spore in an area where they picked it up, not necessarily Santa Fe, but then develop the disease. And so it would be diagnosed, if it is diagnosed at all, up in Santa Fe. But presumably it's in, again, more desertic areas, so as we move farther west, southwest in our state, out towards Hidalgo County, Luna County, it's believed that there is more risk of exposure there. That said, there's risk of exposure, theoretically, all of the southern part of the state and up to Socorro.
What current initiatives are in place to combat valley fever, to bring the cases down in New Mexico and in Chihuahua?
Well, one thing is people are not going to spend a lot of money or effort unless they know the true burden of the disease. Without having a lot of cases diagnosed or at least reported, the issue becomes, are our clinicians picking up on the disease? Do they know how to diagnose it? And if they can diagnose it, do they know how to treat it? So we carried out, in 2010, we carried out a knowledge, attitudes, and practices survey to about 14% of all the clinicians in the state, it's probably 3,500 odd clinicians in the state. And we found that more than 2/3 admitted that they did not know how to diagnose and treat valley fever. So this means that more than 2/3 of our clinician base is not familiar with the disease, or at least would not suspect the disease if they were looking at a pneumonia, thinking first it's bacterial, viral, and treating it for such. But those antibiotics don't have any impact on a fungal infection. So that became an immediate issue, and in May of 2010, we had a face-to-face continuing medical education event at Memorial Medical Center. It had about 65 clinicians come in to receive 4 hours from face-to-face from experts from Arizona. And then we started an effort to try to bring it to the public's awareness, because in Arizona it's found that if people are familiar with the disease, they'll ask their doctor, could it be valley fever, could it be valley fever, and they'll get diagnosed sooner. Not to say that every infection is valley fever, but it should be considered a possible diagnosis when symptoms are present. So it's, in New Mexico, we have a public awareness campaign. We are premiering a documentary on valley fever on the 27th of June at Doñana Community College Creative Arts Auditorium. The patients that appear in the film will be there for the premiere, and it's hoped that we can get the knowledge out to many people.
As we discussed creating a BiNational network of care, a program recently established by the Office of Border Health and the state of Chihuahua to reduce the numbers of Mexican national mothers seeking to give birth in New Mexico, and more specifically Luna County, has been seen with some success. Tell us about the program and how it came about.
Well, this came up as an issue during the strategic planning session back in 2007. So the solution was seen as developing a protocol to regulate the entry instead of the current situation where anybody that presented and declared a health emergency, they would be given a humanitarian parole. 911 was called, ambulance picked them up and took them to the hospital. The issues were multiple, or multifaceted. One is we can't expect customs agents at the port of entry to triage people and according to their health conditions. That's presents liability to them and to the patient also. The other is in Palomas there was very limited health care available. In fact, there is the Palomas Health Center, but it was run down. It was poorly stocked. It often didn't have electricity, and clinicians assigned there wouldn't be at post, because Palomas in many cases seen as an outpost town. So we began an effort to get the Palomas Health Center rebuilt and expanded. And this was in the bilateral agreement we discussed, so it was all the way up to the governor that wanted to get this done, or at least had signed an agreement that had the will to be done. Problems is budget always, but eventually they came up with the funding, and they did reconstruct and doubled the size of the clinic, and then we got better staffing in there and supplies. And so now we had a way to say, wait, there's no reason to cross into New Mexico, go to the hospital in Deming for anything but severe trauma and I guess complicated births, just anything that was outstripped the capacity of the doctors there. So we sat down with Customs and Border Protection, we sat down with Chihuahua State Health Services, Members Memorial Hospital, Columbus EMS, and worked out the protocol. It essentially required that all patients who who may indeed come into New Mexico or need to come into Mexico for emergent care, first go to the Palomas Health Center, be triaged by certified clinicians. Those that could be helped there, or those births that could be assisted there, they would be assisted there, and there's no reason to come over. Those that, because of some complications, severe trauma, gunshots, cardiac arrest, They don't have the time to be transported to either Juarez or Nuevo Casas Grandes. Deming Hospital is 30 minutes away, and so there was always, and there is always, an opening for people who have to come across. But you know, from a height of 2009, at the highest point, there was probably 150 women, and I'm talking about Mexican national women who are not U.S. citizens and do not hold a visa for multiple entry, crossed into Mexico at the Columbus port of entry, were transported to Members Memorial Hospital and gave birth there, and then returned to Palomas. That was in 2009. With the implementation of the protocol, those numbers have come down to 30 or 35 a year. So it has had a big impact, but the intent was multiple. It was assisting Mexico in developing its capacity to treat its own clients, its own population. And this is where we go back to coordinated binational network of care. If need be, we can help. If need be, they can come in and access the hospital for truly emergent care. However, if it's a regular birth or a suturing or something like that, that doesn't require, is not life-threatening, then certainly at the Palomas Health Center they can deal with those.
How was it received, you know, on the Paloma side to have their own clinic that, you know, that they can depend on, and, you know, these mothers that were having to come to the U.S. because, again, they were not comfortable in the conditions that that they had? Yeah,
you know, it's a two-way street. One of the reasons that the Palomas clinic was left to be run down was because of the open door policy at the port of entry. So we had discussions with the Chihuahua State Health Services. Why should we be investing $350,000 to rebuild this clinic if you're going to continue letting it was Chihuahua State Health Services requested the protocol even more than anyone else, and they said, we're not going to invest in a Palomas Health Center if you're going to continue to let everybody in, because they're not going to come visit our health center. And they were right. If there's an open door policy, if anybody declaring a health emergency, whether it's emergency or not, and it's not always an emergency, if anybody can go up and say, I need to go to the hospital in Deming, and you know, they're allowed to do so, then people get this idea that, well, there's open door policy here, which is not bad, but it had an impact on the Columbus ambulance service and Members Memorial Hospital, because these are costs that are not being remunerated. So,
approximately, you know, as we look at, you know, just look at some numbers, how much money was invested to rebuild the clinic versus how much money does it cost to, in the past, to have been brought in somebody through the ambulance services and, you know, the birthing costs that it was costing Luna County?
You know, I don't know exactly. The hospital could better present that information, but certainly $5,000 to $7,000 in a 24-hour stay and birth and assistance of clinicians, somewhere in that range, versus, and that would, you know, would be anywhere from $7,550 per year versus $350,000, which was what was spent to rebuild the Palomas Health Center, and fully equipped. I shouldn't say fully equipped, but well equipped in comparison to the way it used to be.
You rely a lot on educational programs to get the word out to people about, you know, what's going on and keep them informed. What kind of educational programs did you put out to let people know, you know, that they can that the clinic was available to them, and, you know, what kind of protocol they should follow? You
know, our research shows that the best form of media is word of mouth, like the game of gossip. That said, there are limited outlets for disseminating information in Palomas. Also, at the time it was opened, it was election season, and it's prohibited to have any type of open house or some type of celebratory event for public infrastructure, because it's seen as a way to give the edge to the incumbent, if you will, the incumbent party. So we didn't have one. We wanted to. We proposed to. It was in our plan. That said, the doctor started off very quietly, and then with the application again of the protocol, all of a sudden the numbers started coming up. And you know, now they're up to about 400 consults a month, when they used to have 60, 80 consults a month at the health center. So it really has it's being much more fully used. And so word of mouth spread through the village. The clinic's open, the doctors are there. You know, they're not such bad people. It's a real clean place. Let's go to the clinic in Palomas.
Is this a model that can be used in other border states that might have this kind of problem?
You know, it's been hard to verify. Obviously, in the past, there were similar instances. Recall a situation in Douglas, Arizona, and Agua Prieta, Sonora, similar type of situation, that people were coming over into Douglas and overwhelming the hospital there, which only has like 19 beds in that hospital, much smaller even than Deming. And that provoked Congress to find a way to reimburse these hospitals and ambulance services and physicians that attended to people coming over. Because we are a pay fee for services health system. Mexico's is not so much subsidized, but it's state run, if you will. People pay into a Social Security system and are immediately taking out their benefits as health services. Here you have to have insurance or you have to pay.
Well, I appreciate you coming in. You know, I think we have a lot more to discuss as we move forward, because I mean, there's a lot of issues that are of importance: influenza, and again, discussing more about valley fever. My guest has been Paul Dulin, and he is the Director of Office of Border Health with the New Mexico Department of Health, and we've been discussing a binational network of care on Fronteras. Thank you for joining us.